Yes,
Sure.
there you go.
Okay, back to the results of the lecanemab trial. So what we saw in this trial was a significant improvement of the cognitive worsening over time, and I think also very important when we had a look at the Centiloids based on quantitative amyloid imaging, we also saw a clear decrease, and this already occurred after 6 months, and you can nicely see that there was really a large effect on the removal of these amyloid plaques. And still, we should keep in consideration that this is a trial design, so it's not like a real world setting, but still this trial design was able to meet the primary endpoint. I think that is so important there, and primary endpoints are not so easy to meet all the time. So I think we should take this as a very good starting point because we can see positive effects with the treatment. So when we have a look at the history of the approval, then this really took now a long time in Europe. So we had the EMA submission in January 2023 of lecanemab. We had then several approvals in different countries in 2023, 2024. And when we then had, unfortunately, the negative opinion in July 2024, so we started to get a little bit nervous. And however, now finally we really got the positive decision in April 2025 with the exclusion of the APOE4 carriers, which was of course also expected based on the decisions in different countries. So for the second treatment that met the primary endpoint, donanemab, we now have a negative opinion currently, but of course it will be of interest what happens there in the next future then. Yeah, so when we talk about the amyloid status, of course, we need to discuss how to assess this best. And I think currently, of course, it is very important to just follow the recommendations of the neurologists and to have a look what they think that is a good pathway for the diagnostic algorithms. However, of course, keeping in mind that this needs to be challenged with the real-world settings. So when we talk about Alzheimer's disease, we are here in the left branch of suspected AD after a clinical assessment. And in these current algorithms, you can see that CSF biomarkers are in principle favored because they are better accessible. So all these algorithms were, of course, evaluated for being available in a large proportion of the European countries. And here, CSF, of course, is still better available than amyloid-PET. So it makes sense that they thought this is maybe the wave 2 and not the wave 3. Yeah, however, then still we have here the questions, what happens if you have this borderline cases and then a negative CSF, but a positive amyloid-PET? So how often does this happen? So also it's the question needs to be asked, what is borderline A beta in the CSF? So this is also not really defined. And of course, you need to question this algorithm because here FDG comes into play, but would you really do that before disease-modifying treatments? And I think we can already, now looking at the SMPC, we can say no, because we need a better status and not an FDG PET to prescribe the disease-modifying treatment. To answer the question on this threshold and borderline, so we catched up with the colleagues in Vienna and we analyzed our real-world data 2013 to 2023, and we had a total of 408 cases with suspected AD, and we analyzed CSF against PET, and I think that's really interesting results because we can learn a lot for the real-world setting. We had 45 that were positive with a ratio, a beta 42 to 40 ratio of 5.5%. And we had then 31 that had a beta ratio above 7. So these were very clear, only 5% amyloid positive afterwards. But then, and if you look above, so also 90% were positive in the group of CSF positive. But what was really the interesting group that were those that really are at the borderline level. So this was determined data driven between 5.5 and 7. And here you can really see it's the ideal situation, of course, for a diagnostic test. You have a 50-50 percentage of positive and negative amyloid PETs. So in principle, in this range, if you would have called them negative, as we had done in our laboratory readout, so they were amyloid negative per definition. But here you had 50% of positive amyloid PET scans. So this really makes sense, of course, to really assess this group with an additional amyloid PET scan. And we also checked this across different cohorts. So what you can see from this graph is that this borderline is rather consistent. So we applied data-driven approaches. We analyzed the cohort in Vienna, in Munich. And what you can nicely see is that this borderline, if you define it between 5.5 and 7.1 or 5.4 and 7.2, so depending a little bit on which data-driven approach you use or which cutoff you apply, but you still see always this borderline percentages ranged for a positive amyloid PET ranged around 50%. So this seems to be quite consistent across data and of course should guide us to do amyloid PET in these cases. And so what our current approach then also for DMT assessment would be, we have of course some cases that should directly go into PET. So for example, people that are much afraid of the lumbar puncture or that have any contraindication against the lumbar puncture. And of course, then we need to do the PET and decide based on the amyloid status in the PET. But then, of course, we have here the situation that we can also judge based on the A-beta CSF, so do that as a first evaluation, and then decide based on the CSF or then on a second amyloid PET scan if you should include them into a treatment or not. So this would be our current idea in Munich to really onboard the disease-modifying treatments then in a real-life situation. And yeah, so then, of course, we need to ask, what is the value of quantitative amyloid PET? And I think this is also a clear decision. So we did not yet analyze the quantitative values of this cohort yet, but what is a clear take from all different studies? So there are many cases that are really clearly negative. There are also many cases that are clearly positive, but you can see that especially if you have intermediate amyloid levels, and I think we will find more and more people that already come to the clinics early in their disease course and that will be at these intermediate amyloid levels. There we need this quantitative amyloid PET because here we have a lot of false positive or also false negative reads of the amyloid PET scan. And this is exactly the situation, of course, where we will have the need for also quantitative analysis. So, and how can we do this quantitative analysis? I think Centiloid quantification is now also a tool that has made a lot of progress during the last decade. And I'm often asked, why can people have negative amyloid Centiloid values? So you just need to have a close look how this is calculated in the end. So in principle, what is the interesting thing of Centiloids is you can inter-exchange it between different tracers. And what you need for that is you need to define a group that is amyloid negative, so unimpaired people, very young or younger adults, and there the mean value of these younger adults, that's the 0 point. And then you have a group of mild dementia, and this is defined then as the average is defined as the 100. But of course, you can have people that have more amyloid in the brain, even in that group, so they will be above 100. And of course, also people that are below or are at the lower range of this control group, there you will get, of course, then also negative values. So that's the easy explanation. However, with that 0 to 100, you can nicely define a scale that is not perfect, but that at least gives you a good idea of if the patient is full of amyloid quantitatively or if it's more in also a borderline range. And that these values work nicely. I think that was also nicely shown at the AAIC 2023, here in the IDEAS cohort, so really large data set with 10,000 scans. And so here you can then also see what's the distribution of the Centiloid values. And you can also see from that there is a more than expected also in a range that were not so clear for the quantitative value, also between, especially this borderline range between 20 and 35. And what is also interesting, you can use, of course, such large data sets then with different tracers to have a look at the different compositions per tracer, if they are depending a little bit on the imaging window. So if there are any correlations between the imaging window and the quantitative values. Yeah, so the second thing where I think that quantitation is very important is monitoring. And this was presented at ECCN 2024. I think this is quite interesting data, because if you look at the different phase 3 trials of the amyloid disease-modifying treatments, then you can nicely see that the trials that really cleared the amyloid of the patients below the detection limit, these were the trials that met the primary endpoint, also in terms of cognition. And the trials, so even the arms of the different treatments, so for aducanumab, here the ENGAGE arm did not meet or did not clear, and also did not meet the primary endpoint. And also the gantenerumab trials, they failed to remove all the amyloid from the brain, and also failed to meet the primary endpoint in terms of cognitive worsening. So this should definitely also guide us towards a personalized medicine then. Yeah? So we should evaluate in the future if this is also applicable to the individual patient level. So if it's important to remove all the amyloid from the individuum, and then see if these are the patients that really profit from the treatment. And finally, I have 2 cases for you where you can also see that quantitative amyloid-PET is important. So this was a 77-year-old female MCI, and also a borderline amyloid ratio. So here 6.2, so that was exactly in the range where we defined then our borderline cases. p-tau was not pathological, and so we did an FDG PET scan, and here we got, so these are Z-score maps, so everything in red is hypometabolism, so posterior pronunciation, and also received an amyloid PET. And here you can see, so the amyloid PET is clearly positive, so you can nicely rate that. However, so if you look at the average ratio of SUVR, so we had no Centiloids that time, then you were at a moderate level, 2.97, so not that much amyloid, and also not all regions very strongly affected, however, like the posterior cingulate cortex with some Z-scores above 5. Now then, we were still not so convinced in this case, so we performed a tau PET scan. And what you can see is, so the regions, the posterior regions that were very hypometabolic, they were not positive in tau PET. So we would have expected in an Alzheimer's disease case that the same regions that have the hypometabolism are also tau rich in the end. So we still questioned that case, and so we performed a DAT-SPECT, because so we found some occipital, so the occipital lobe was involved. So we thought, could be maybe also like a DLB pattern. And we also saw some cortical, so some posterior cingulate island sign. So cingulate island sign was also positive. And the DAT-SPECT also, was positive. So still not a proof of DLB, but thanks to the new upcoming alpha-syn-seed aggregations assays, so we were able to define this case as an alpha-syn positive individual. So here you can nicely see that in cases where you already have a very strong hypometabolism, but only moderate levels of amyloid, maybe we should also question these cases, because there the amyloid could just be the co-pathology and not the primary driver of that what the patient has as a disease. And so this is not the only case. So there are many cases around, and also published cases here in the European Journal, for example. And here also the clinic should guide us, because here we have a severe dementia, minimental state, so any single item was positive here. And also the amyloid PET scan only delivered like a moderate signal. And so the postmortem assessment also gave only moderate amyloid, but identified DLB with amyloid co-pathology as the reason for the dementing of this case, or the primary reason. So I think this is very important, and with this I want to come to the conclusion. So I think amyloid PET is really a powerful tool, which will now become more and more important in the European Union due to the approval of the DMTs. Visual reading is, of course, okay for stratification in individuals with and without Alzheimer's disease pathophysiology, but I really want to pronounce that quantification could have a strong impact for an optimized patient stratification. So to really select the ideal patients for these new upcoming treatments. Yes, thanks. And I'm then taking questions in the end.
Thank you very much. Thank you very much, Professor Brendel. Well, I think you pointed there quite clear, no? The need for one of the challenges, that I pointed out at the beginning was the number of cases that potential cases that we are going to face, and so this kind of journey that you have exposed is it's going to be very important, no? To have all the information needed for who's really eligible for these particular cases, and to give the patient obviously the best possible treatment for them, but again making that sustainable for the system. So it's very important. Thank you very much. So after that we're going with Dr. Pedro Plaza. Like I said, Pedro has been working with Neurocloud already with other tools again, Syncovia and all. So he's quite an expert in this kind of use for the daily work, and he's going to expose. Nobody wants to be called an expert, but you are. And so he's going to talk pretty much like Matthias said at the end. What's the new information? Because that's something again that's happening in the recent years. No, at the beginning when we began with Neurocloud some years ago, almost a decade ago. There was even the question: is this kind of tools are going to change the way we work? Are going to erase my work? Am I going to be substituted by an AI? No, it's just again new tools that provide new information to provide better information for working in your daily routine, and that's something that Pedro is going to show you how he does it every day.
Okay, so thank you very much, Manu, for your invitation. I have nothing to add after the Matthias talk. So I just want to show you our experience working with Neurocloud. So I would like to show you just a recent paper, which is an update for appropriate use criteria for amyloid and tau PET. And just for example, this paper classifies the clinical scenarios for amyloid PET in appropriate, uncertain, or really appropriate. So now I am going to show you the cases, not a tricky cases, is just our routine clinical scenarios. So the first one is a male with it was 64 years old with history of hypertension, high cholesterolemia, and von Willebrand disease. The patient has mild cognitive deficit with memory impairment and with progressive worsening in the recent years without affective symptoms or stress. The brain MRI not showed significant alterations, and we think that we are in a probably early stage of Alzheimer's disease. This is the visual analysis of our PET with for beta-pen, and it does not show significant uptake. So we report it as negative. So why we do the Neurocloud analysis? So we do that because Neurocloud gives us quality information, and we think that this section is crucial because it allows the validation of the technical quality of the study, the comparison on patient uptake with the normal and pathology patterns, and allow understanding of the specific anatomical region used for quantitative calculation, and allows the verification of proper spatial normalization of the images. As well, Neurocloud gives us or provides us a detailed axial, coronal, and sagittal imaging sections with segmentation of brain region in color. provide anatomical details of the distribution of the radiopharmaceutical at multiple levels of the brain. That's allow clinicians to assess specific regional patterns of uptake. And in the quantification section, we have two tables. The first one is a regional analysis table, which contain the regional uptake values, the percentile, and the set score for brain regions. The regional patterns have the differential diagnosis value. For example, highest values in orbitofrontal and parietal regions in the left hemisphere could be consistent with early patterns of amyloid deposition. Percentiles and set scores contextualize these values with respect to the normal population. And the plot charts give us a visual representation of a regional uptake values compared with the normal ranges, and facilitating the identification of regions with a normal uptake, highlighting those that exceed normal limits, which is the dotted red line. So, following in the quantification section, we have the most critical section and useful for clinical interpretation. We have a visual scale in colors, green, yellow, and red, about the Centiloid scale values, which facilitates a rapid interpretation and the numerical result. In our case, in this case, the numerical result, the Centiloid value was 8.4, so it was in the green zone, so it is negative. So we have a value, a Centiloid scale negative, visual analysis negative, so the patient was not suspicious of AD. Next case is a 68 years old male attended for cognitive deterioration of insidious onset and slowly progressive course of 3 years of evolution, consisting mainly of memory problems. The patient was diagnosed with an amnesic predominant mild to moderate cognitive impairment, clinically compatible with Alzheimer's disease. Cerebral fluid, spinal fluid was initially proposed because it's our standard practice. I think it's the standard practice for everyone, but the patient refused it. So we perform a PET amyloid. In addition, the patient voluntarily participates in a study using plasma biomarkers. So we have here our PET amyloid, which was a little bit doubtful. We reported as probably positive for discrete amyloid uptake in frontabasal and temporal lobes. But when we do the quantification done by other softwares, the regional uptake value was not positive. Even in the old version of Neurocloud was reported as negative, as you see here. But when we do the new Neurocloud version, it was positive with a Centiloid value of 35.8. In addition, the plasma biomarker was in a high-risk range. So finally, our final diagnosis was Alzheimer's disease. And the third and last case, sorry for the large introduction, was a male for 75 years old with enolism. He has deficits in verbal memory and verbal fluency similar to previous controls, with no changes at the functional level. He has a very slow progression. At the behavioral level, there is an increase of irritability. The biochemical profile, CSF, was compatible with Alzheimer's disease. The MRI cranial not show the notable alterations, and we have a previous PET amyloid 1 year before, and it was reported as completely negative. And that was performed in a external center. So we have an incongruence between the fluid, the spinal fluid, and the previous amyloid. So we performed a new amyloid, and this amyloid PET was clearly positive in all lobes. We perform the quantification by Neurocloud, and the value of Centiloid scale was clearly positive in the red area, so it was 85. That quantitative will be very, very useful for the treatment response monitoring in clinical trials nowadays, and probably in the future in the treatment of that kind of patients. So I would like to say you that as a summary, Neurocloud can help us, the nuclear medicine physicians that work with neurodegeneration, in increasing the accuracy of PET amyloid, in standardize the whole process. Is independent of the MRI. We don't have to use it for nothing, and give us a reliable quantification useful for treatment response monitoring. So thank you very much for listening.
Thank you, Pedro. Thank you very much. Well, just we wanted them besides the Centiloid scale. No, I told you, no, that we have been working with. I think you have to share the screen. Probably. You have to press on detener compartición. I think in the upside. Yeah, there you go. Okay, thank you. No, like I said, no. So Centiloid scale. Well, obviously it's one of the reasons though where when we began to think about the webinar and so on, because that's something that we have been requested more and more. Until now we have been working just with SUVR. No, we had a proprietary list of a database in which we knew the threshold, no, let's say for each of the main traces that were on the market. But again, since it's not mandatory yet, because the approval just happened, no, but people from Portugal, from Spain, from Italy were already demanding this Centiloid scale for quite a long time. Pedro, I think, for even, I don't know, 2 years probably or something. I mean, you were one of the very first that were requesting this feature. And so, for instance, in your case, Pedro, that's the question. No, how in those cases, well, though you have exposed it already, how the Centiloid scale has helped, or what was missing it when you were using this UVR. And that's the first question, but it's a short one. And the second will be for the two of us, for the two of you, will be well, given the new. It's not yet the new situation because steps have yet to be done. No, it has been the first approval for Europe. Then each country has to approve the treatment and well, specific rules. Let's say, no. But is it's still something that you're already doing in your departments, or are you getting ready, or just are expecting to see what the next moves are? Because, like I'd say, no, that we already know, it can suppose a great amount of new, let's say, patients, no, to be treatment and taking care into the hospital, which I'm assuming that you are already quite busy and you don't have very much free time, no, for doing things. And so, are you already doing something or getting ready with your teams for what's to come, or how are you facing all these new situation? That will be my two questions.
Well, I have to say that amyloid PET is an easy exploration for nuclear medicine physicians. Most of them are clearly positive or negative when in the visual inspection. But when we are in the gray area, we are not completely sure. And this kind of quantification help us a lot in order to be confident with our report. So the idea is you have softwares like Neurocloud or other ones that show us a number, the Centiloid scale, and it is really convenient. It makes easy the process. So we are really busy, and when we use this kind of tools, we can do our job more easily, more faster, and we feel more confident, and our clinician, our neurologists feel more confident with our results. So I think that is very convenient. With the approval of the lecanemab, we think that we are going to increase a lot the number of PET amyloid. So probably this kind of tools help us to assume the great amount of job that is coming to us.
Yeah, I think that's a really interesting question, and so we were also questioned if we have the capacities to perform these amyloid PET scans. So this so we conducted in Germany a survey across the different nuclear medicine institutions. So and I think that was quite valuable, because so we really saw that with a situation where reimbursement is granted, there all institutions really saw a large chance to increase the capacity. So we would not see a bottleneck in doing amyloid PET imaging. So the bottleneck we see in the hospitals is more, as long as these are infusions, it will more be the infusion sites and so the places in the clinical department. But like the amyloid PET imaging, I think so we could nicely cover. So we saw, so I think it was 400% increase what could be achieved easily with the sites that participated in the survey.
Okay. It's good to know. It's good to know. We're very, for me at least, I wouldn't say unexpected result, but what more good news, I would say. No, the answer to the subject, very interesting. And well, of course, I went ahead with the questions, but please, everyone who's right now within the audience, please do go ahead and ask any question that you would like to know. Now, one question that I also have is, until now, no, we were born. Actually, the first algorithm that we developed was the one for FDG. No, now we have for FDG, for amyloid, for white matter lesions, etc. Now, how are you think are going to work together? No, I mean, until now, you used to have in the majority of the cases, not just one majority of the cases, the ones who have FDG, no, but now, how are they're going to co-live or to coexist the FDG with the amyloid and this kind of tests of studies for Alzheimer and so on.
So may I start there? So this I think this depends a little bit on the site. So we do much less FDG PET, because we do in nearly every amyloid PET scan we do also perfusion phase. So with a dual time point protocol, so we do the first 10 minutes. So this works very nicely. So you could even do 0 to 5, I think, but 0 to 10 is rather robust, and so this gives a really nice readout. And so you can have then two opportunities with that early phase scanning. So first, of course, in people with Alzheimer's disease, you will also have a staging of them. So you will see how much their brain is already affected in terms of neuronal dysfunction. And the second thing, and I think that's even more important, in this 43 negative cases, you would just need to be you would just be able to tell that they are amyloid negative. But so with the pattern that you get, so you can, in a lot of these cases, you can really tell, okay, this patient is amyloid negative, but based on the perfusion image, we would suspect that it's a frontotemporal dementia, for example, or cortical basal syndrome or anything. So this is I think this is heavily valuable. So we analyzed our data, and I think at least in 30 to 40%, we were able to really delineate a pattern that guided us towards a disease as we had seen in FDG PET before.
Okay. Great. Okay, so we have two questions. The first one is anonymous. Let's see that. Let me read the question first, just in case. But no, Now, jokes aside, is even though Centiloid scale purports to be interchangeable between traces, there still seems to be parameters at the calculation of Centiloid score that lead to a deviation in different softwares, no, that are used, which is true. There are some works already, some studies. So the question is, do you think there are significant deviations, or could it be this optimized? And thank you very much, let's say, for your presentations. So yeah, I mean that's the point, no? So because obviously, no, the final goal for the Centiloid scale is again, no, the standardization, the harmonization, let's say. So
So I think that the idea that the Centiloid scale is developed for or traces, and we think that they are interchangeable. No, so you can use all the three traces. They are commercially available nowadays. I think they are not significant deviation. I think we can use it without doubts nowadays.
have you tried? I mean, well, I don't know. Maybe, well, Matthias, I don't. Sorry, I don't know where.
Yeah,
My
I think
question was, if have you tried the same case with different
No, the same case.
calculations in?
yeah. So of course, there are some deviations, especially if you choose, for example, different reference tissues. So this there you can sometimes face some differences. However, I still think so these differences are tolerable. So in if you weigh what you win with a unified scale and what you may lose with some deviation, I think that is still very important to use a unified scale, especially if we want to be compatible with fluid biomarkers. So we need to have such a unified scale to really have a tool that is understood by most of the people in the field, and not only by nuclear medicine physicians. And I think that's important.
I absolutely agree. I mean, many times what we face, and I think this is related, we want to go, like I said, from 0 to 100, meaning in many cases we don't have the tools. No, we are used to work in our daily routine without this kind of tools. And then when this kind of tools or solutions appear, we tend to focus on what's the situations or the cases in which they are not 100% reliable. Let's say, we always say that most of these cases, or most of these tools, not only Neurocloud, but most of them, or not tools, I would say methodologies, no, because in here we are discussing about Centiloid scale. It's meant to work in the majority of the cases. Obviously, every method, every tool can always be improved, but this is the best we have right now. So
True.
why shouldn't we stop there? No, I mean, but that's something me that again, in my particular case, I'm like we say an early adopter of almost everything. So I'm always I'm always in this thinking that, no, okay, if this is we have the best we have, why shouldn't we? No, then okay, it can be better, but let's use it. No, right now I think it's a very simple, no, let's say a good tool for working together in this moment in which sharing information is going to be so important again, no, because in these moments that's the key thing. So there's another question from Ana Moreira. It says, "Good afternoon and congratulations for your presentations. I would like to know what meaning do you give when you find only focal uptake in a region in the amyloid PET scan? I found that pattern sometimes, and I usually reported it." So that's the question. No, what do you what's the meaning that you give to that? No, when you just find the focal uptake in a region in the amyloid types.
Yeah, thanks, Anna, for that question. I think that's important. So I think first, of course, we should stick to the reading rules of the tracers. So it depends. So focal uptake, if you can only see it in one slice, you should not weigh too much. But if you can see it consistent across 2 or 3 slices, then of course, it's in principle a positive scan, only also with one region positive. So this is something we need to consider. But then we should still also consider that we only rate this amyloid PET scan as a biomarker of pathophysiological phenomenon that occurs in the brain. So, and of course, in such a case, we should also take into consideration then together with the clinicians the stage of this patient. So if this patient has a minimental state examination of 15 or so, then the amyloid is maybe not the cause of the problems that the patient has. So we always need to consider, of course, the individual patient then as well. And I think in such a case also like the perfusion or an FDG will also help, because then you are also better able to judge if this amyloid positivity, so it would be an amyloid positive case, but the question is what you make out of this amyloid positivity. So if you then think, yeah, this is what you need to treat, or if this is something that is maybe just like a cool phenomenon that can occur in an older people or an aged people as well.
All right. I don't know if Pedro wants to add something.
Well, no, the idea is we have not to analyze alone the PET amyloid. So we have the different tools. We have the perfusion, we have FDG, even the clinical, even the MRI. So we have to analyze the whole patient in order to give the clinicians our report and our idea about what is happening. No.
Perfect. Well, it's 5 minutes to 5 here in Europe. I think it's sunnier in Munich than in Spain right now.
It's really sunny.
Yeah. So I'm going to liberate both, especially Matthias, for before the sun makes some damage in him. Just I wanted to tell everyone, thank you very much for your presentations. Those were great. I think the goal was achieved, no, to give a quick but well done presentation. No, what's the situation right now? What's the approval? How's the approval going on? And then some specific cases in which it will help us. It has helped and it will help, and so and it gives us an idea of what's to come. No, for the rest, no, for the people who has to it, I'm gonna write. Well, I have put in the chat our mail. It's hello@qubiotech.com. Because should you want to try your own cases with the Neurocloud platform, I didn't say, but it can be used either cloud versions, on-premise version. Okay, one of the goals, like I'd say, is to provide a second objective opinion, and it tries to be integrated in every kind of situation. So we have all different situations. One of the good things is that you can try by yourself. No? So please, should you want to try it, Neurocloud, by yourself with your own cases, please write us to the mail and we will get in touch to any one of you. Of course, we are CMARC. We have been for quite a long time now. And by the end of the year, we hopefully will be FDA. Let's see if things don't change very much at the States, but everything should be done by the end of the year. So please do not hesitate, or of course, any further questions that you will have or you may have for the speakers. All the webinar, it's going to be shared at our YouTube site and our website, and I will, I think, send you to all the systems the email, the link, so that you can watch it again as many times as you want. So again, thank you very much all for your participation, for your work, and have a good day. See you soon.
Thank you for listening.
Bye.
Bye-bye.
Bye.